It's just another grand round. I have the pleasure to introduce today a professor who came from the US for one of our PhD students' defense and who gave us the pleasure to give out a few talks with our residents. And it's a personal and academic pleasure to introduce Professor Chris Pittenger, who's an MD and PhD. He's a full professor of psychiatry at the University of Yale and in the Child Study Center, his deputy chair for translational research, director of the Clinical Neuroscience Research Unit, director of the Yale OCD Research Clinic, and director of the Neuroscience Research Training Program, all within Yale Psychiatry Department. You can ask yourselves, when does he sleep? He's director and co-founder of the Yale Program for Psychedelic Science and the Yale Center for Brain and Mind Health as well. And as our commentator, we're going to have Professor Euripedes Constantino Miguel Filho, who's also a psychiatrist and a full professor. He's the head of the Department of Psychiatry at the University of São Paulo and associate adjunct professor at the Yale University School of Medicine, also general coordinator of the Center for Research and Innovation in Mental Health, CISME. They've known each other for a very long time, and I'm sure we're going to have a lot of fun listening to them discuss neuroscience and clinical practice. Please, Chris.
You got a few minutes.
You've done this a few times. You've done this a couple of times. You should be all set. Yeah. I wanted to remove the controls, but if you're good.
All right.
Oh, yes, this.
Well, thank you, Ilana, for that introduction. Thank you, Yuri, for the invitation to be here. Many friends here, and more each time I come, so it's a great pleasure. So I was asked today to talk on a broad topic: how does neuroscience inform clinical practice? And I'll share a few thoughts. I'm going to show some data, but sort of as examples. I'm not going to go deep into any research. Some of it's my own, some of it's published. Share a few thoughts. I'm happy to be interrupted at any time, and I know we'll have a chance for discussion at the end as well, but please don't be shy. If anything I say doesn't make sense, or if you want to jump in and ask me to elaborate, I'm always happy to. I don't know if this is standard here, but I always show my disclosures. I do consulting for various companies. I get funding from various places. None of this has anything to do with what I'm sharing with you today, but there it is. All right. So the last several decades have been a truly astonishing time of progress in our understanding of the brain. I first discovered the brain and started to think about it when I was a college student in 1992, and so many things at that time were mysterious and impenetrable that now we know. Also genetics, also other aspects of science. Brain imaging has advanced. We have new theoretical models of information processing. It's been an exciting, few decades that I've been in the field, and our knowledge continues to increase exponentially. And a little slower, but we are beginning to have a little bit more of an understanding of the causes and the brain correlates and mechanisms of psychiatric disease. Let me say at this point, I am focusing on neuroscience and the brain through most of this talk. That shouldn't be taken to mean I think that all psychiatric disease is all in the brain, or that it is all explicable by neuroscience. I don't. It's just the topic for today, and we can talk about some of the complex interactions between different levels, between the genetic and the brain and the psychological and the social, perhaps during discussion. But I'm going to be fairly brain-focused today, because that's the topic. But anyway, I'm just illustrating here some various, EEG, genetics, brain imaging. We're starting to know more about the underpinnings of psychiatric disease, right? Which makes it a little embarrassing that you can be a pretty good psychiatrist without knowing anything about the brain, right? I mean, what are our tools? Our primary tools are psychotherapy, for which being well interpersonally connected and versed in evidence-based practices and other theoretical frameworks matters, none of which has anything to do with the brain. And we use medications. And of course, the medications act on the brain, but we don't really use that knowledge when we're prescribing them. We use our understanding of their indication, of their side effects, of the doses, of the drug-drug interactions. I mean, knowing about the liver is maybe more important than knowing about the brain when you're doing complicated medication regimens. So there's this tension that I suspect most people in the room and online think that understanding the brain is both interesting and important. We do understand it a lot better, and yet it doesn't very much inform our clinical practice. Well, I think that's changing. I think 10 years ago, if I was giving this talk, it would have been pretty theoretical. I would have said, I think that it will change. I now think that it is changing. And I think that to be a really well-versed psychiatrist with all of the tools to help our patients at hand, you do need to know something about the brain today. And I think you'll need to know a lot in the coming years. And so especially for the young people, I think that it's essential, even if you're not planning on being a researcher, even if you're not particularly interested in staring at brain scans, I think it's essential to understand the basics of the brain mechanisms that underlie our disorders, both for practice today and for metabolizing or absorbing the treatments that will be coming in the couple years. And I'm going to give some specific examples and some thoughts about why I think that that is true. In the same way that, you can't be a good cardiologist without knowing about electrical conduction in the heart, right? Maybe most of what you're doing most days, you don't use that information, but you need to know it. And your patients expect you to know it. And so I think that this, which wasn't true when I was training, it was kind of an act of faith that understanding the brain was going to be an important thing for a clinical career. I don't think that's true anymore, and that's what I want to talk about. And I'm going to talk about some examples of why the relationships of brain to psychiatric symptoms are important to clinical practice today. And I'm going to talk about how it's increased, understanding the basics is extremely important for our trainees and people starting out today, because it's going to be more and more important every decade going forward to understand the new advances for care tomorrow. Okay, starting with today. The first point, and actually the point where I use my knowledge of the brain the most in working with patients, isn't about pathophysiology or treatment or brain scans or diagnosis. It's about helping people think about their conditions. And that's the first thing I'm going to talk about. And that's really the first two bullet points here, which I'm going to go into on separate slides. And then, after talking about that, I'm going to talk about some new advances, new treatments, which can be used today or will be usable very soon. They require a knowledge of the brain in order to deploy them properly. And then some other things that are on the horizon, including a couple examples of work from my own group, just to illustrate the points. But starting out, and this may seem like an odd place, my guess is that when you heard I was going to talk about why we need to know about the brain for clinical practice, that you thought I was going to talk about brain scans for diagnosis or new drugs. I'm going to talk about that a little, but I'm going to start with something much more personal and interpersonal, which is how do we help our patients understand what plagues them? So I'm sure you've all had the experience that some people, if you have two patients, even with exactly the same symptoms, one of them may understand their symptoms in a purely psychological way, right? I'm having this problem because of the distress I had as a child and then the bad relationship, and that's leading to these negative memories, which are coloring my mood, which is making it hard for me to function, right? That's a completely psychological understanding. And people with that kind of understanding usually want that kind of conversation about their illness. But you've probably all also had patients who think about their illness in a completely biological way. I can't get out of bed. I don't know what's wrong. I have no energy. There's no reason for it. My serotonin must be out of balance. Right? And then some patients and some doctors may try to think about both. It won't come as to a surprise to anyone who knows me that I encourage us to think about both at the same time, in the same breath. But our patients often think about their conditions in one way or another, or a combination. So I think that it's fairly clear. Oh, actually, there's a point here. I wasn't able to find the citation when I was finishing this up this morning, but there was a study of the treatment of anxiety, where patients with anxiety, I think it was generalized anxiety disorder, were treated with either an SSRI or evidence-based psychotherapy, CBT, right? But they assessed the patients before treatment to see how they thought about their disorder. Did they think about it as a brain imbalance, or did they think about it as a psychological process, right? And then they treated people with either meds or CBT. And lo and behold, probably not a surprise that the people who thought about their illness as a psychological process did better with CBT. They were more likely to understand it, to buy into the concepts, to engage in the exercises that were prescribed, and they did better. Not a big surprise. The people who thought about it as a neurotransmitter imbalance or some kind of brain problem did less well in CBT, were less likely to engage, and didn't benefit as much. It's more interesting to me that the opposite was also true. So the people who believed that their disorder was because of a chemical imbalance in their brain did better with the SSRIs. And the people who thought it was psychological and the SSRIs weren't going to help them did worse. Okay, they didn't do as well. So this really matters, how we conceptualize, how we conceptualize and how our patients conceptualize treatment. Really matters for not only for thinking about what's going on, but for how we can help them. And it's fairly clear, I think, that if we could get people to a point where both might be helpful or might be okay, that would open more doors to effective treatment. Right? And these days, of course, most patients who've come to you, if your practices are anything like mine, have spent an awful lot of time on Google or talking to friends or, I guess asking ChatGPT to try to get some understanding of what's going on with them, which means that they come with some pretty clear ideas often about what's going on, where it comes from, and some ideas, some of them right, maybe some of them wrong, about how they're going to get better. And we need to be able to engage those. And many of those ideas are going to have something to do with the brain. So how can we as practitioners understand the relationship of the brain to illness, to psychiatric symptoms, in a way that will help us help our patients? So many of you probably, especially those of you my age or older, you may have had the idea that depression is because of a neurotransmitter imbalance. You just need a little more serotonin or a little more paprika, and then you'll be fine, right? This is an old idea. It comes from the idea that monoamine uptake inhibitors, like the SSRIs, are therapeutic, and it's wrong. It's very clear that, and it would be odd given the complexity of the brain and the nervous system and the complexity of our psychology and our behavior if it was that simple that all you needed was a little more paprika, right? So that's wrong. Some patients will still come with it. We need to give them a different way to think about it, rather than the brain as sort of a blob of jello that needs the right sugar and spice to make it work properly. We need to give them another way to think about it. And one way, which is grounded in research, but also is intuitive enough to be helpful, is to think about the brain as a network that processes information. And this is intuitive for most people when thinking about cognition. I mean, cognition, coming up with ideas, remembering things. This is information. The information's stored in there somewhere. I'm pulling it up when I remember. I'm deploying it when I use it to solve a problem. It's easy to think about that as an information problem. It's maybe a little bit less intuitive to think about emotions or drives or impulses as information processing. That's maybe a little bit more of a stretch. I think that they are, or at least partially. I think it's a useful piece of an explanation. But I do think the idea of thinking of the brain as a network that processes information, when I was training 20 and 30 years ago, that was a little bit of an odd idea. It was kind of an esoteric thing that only computer scientists think about. Well, it's not anymore. We all think about networks processing information all the time. The brain isn't a computer in the sense of having a CPU and a memory and the architecture of the computer that's sitting on our desktop. But the basic ideas of information processing in networks and moving information, right? These are common. These are universal. So I think that that's a useful antidote to the idea that it's a ball of jello that needs the right amount of sugar and spice, right? So that's a good first step. And if that's how the brain is working, then we can think of mental illness as a bias or an imbalance or noise in how the brain is processing information. And so it's fairly easy to think about, for example, if your TV is showing you information and you whack it on the side and it gets all fuzzy, actually that TVs don't do that anymore, do they? They just sort of, sorry, aging myself. But if you whack it on the side and it doesn't work as well and starts to get, weird patterns, that you've screwed up the information processing, right? So you can think of mental illness as a disorder in the brain's processing of information. Do I think that that's a comprehensive understanding of all of mental illness? Probably not. Certainly not a satisfying one, but it's helpful. It's a step forward from this sort of naive idea of just magic stuff happens if the level of serotonin is correct. Another thing that I think the idea of thinking of a brain as a network makes intuitive is the idea of feedback loops. And these make sense. These people in CBT and ACT and other psychological concepts of disease think about feedback loops all the time. I'll share, I have some expertise in OCD, so I'll share one from OCD. So in OCD, people get thoughts that come into their heads unbidden, which all of us do, right? We all get weird thoughts that pop into our head from time to time. Most of us ignore them most of the time. In OCD, those thoughts are treated as powerful and important, okay? Because they're powerful and important and distressing. If they weren't distressing, we wouldn't care. We wouldn't call them up. We, as clinicians, we wouldn't care. But they're distressing. They cause distress. So then you do something to alleviate that distress. That leads to relief. Unfortunately, the relief reinforces the idea that they were powerful and important. And it's a good thing, good worth paying attention to. So look at what I just did. I don't have it in a graphic on the slide, but that's a feedback loop. Right? That's a feedback loop from the powerful thoughts to the anxiety or distress to the behavior to the relief to reinforcing the powerful thoughts. So that's a feedback loop. I actually think that most anxiety disorders and maybe most depressive disorders are very usefully conceptualized as a feedback loop, and that fits nicely with the idea of the brain as something that's processing information, right? Now, can I point to where that feedback loop is in the brain? No, I can't. But it's at least using the same language to talk about a psychological level of understanding and what's going on in the brain. So I do think that these perspectives are helpful in trying to understand both psychotherapy and medication. And this is why I think it's in today's context, how can understanding the brain help us with treating our patients? This is why I think this is a good place to start. Because if we can help first ourselves, then our students, and then our patients understand the brain and how it relates to behavior, thought, and illness in this way, I think it helps us understand both psychological and pharmacological treatments in a new way. And that can help us get at the problem that I highlighted on the first slide, which is that someone who believes it's all biology may be walling themselves off from what would otherwise be effective treatments, and vice versa, right? If we can help them to appreciate both by doing so ourselves, then that's a therapeutic path forward. So how do we think of psychotherapy as being of benefit if someone is conceptualizing their illness as in biological terms, as a problem in the brain? Here I think the key concept is synaptic plasticity. So what is synaptic plasticity? Familiar to most, I'm sure. But so the synapses are the connections between neurons in the brain. They pass information from one neuron to the next neuron. Synapses can be of varying strengths. They can increase the first neuron can make the second neuron fire. The first neuron can make the second neuron stop. A stronger synapse makes the second neuron more likely to fire. A weaker one makes the second neuron more likely to not fire, okay? So they are absolutely central to the communication of information through the network that is the brain. Synaptic plasticity is how those synapses change. And it's been known, actually, first theorized by Ramon y Cajal 120 years ago, and then refined by Donald Hebb in the 1940s and experimentally shown beginning in the 1970s by Ladislav Tok, Eric Kandel, who was my own PhD advisor, and others starting in the 1960s. Tok was in the 50s, I misspoke, in the 1960s. It's been shown that synapses can change. We can make them change by electrically or chemically manipulating them, but we can also make them change through sensory input. And when we change synapses through sensory input, that changes behavior, okay? So synapses can change, and when they change, that changes the network, which changes our thoughts and behaviors. So this is what learning is, right? You learn. What happens when you learn? You have an experience today, it changes your thought and behavior tomorrow. Even if it's in a very simple way, like I didn't know who the first president of Brazil was yesterday, and I do know, actually I don't know, but someone will tell me after this talk, and then I will know tomorrow. That's storing information in my brain, okay? So synaptic plasticity is a mechanism whereby that can happen, and it changes the network. So why is this relevant to psychotherapy? Because psychotherapy is learning. right? When we're sitting with our patients and we're giving them new ways to understand and conceptualize their symptoms or their experiences, and we're giving them new tools to manage distressing experiences when they arise, and we're having them go through exercises to learn new habits so that the input-output relationships of their mental system, which is a very geeky way to say it, or the way they feel and think, which is a more humane way to say the same thing, those change because of the structured learning that we're doing during psychotherapy. So explaining to someone, a patient who may think that it's all in my brain, it's all biological, explaining that, yeah, you're right. It may be all biological. And here's one of the best tools we have to fix your network, to change your network so it processes information in a way that is more adaptive. You know, that I have found this very powerful for intelligent patients who are thinking about things in terms of the brain, to give them a way to accept psychotherapy that doesn't require them to abandon their belief in what's going on. And something else that I think is powerful, this is especially applicable to CBT and other sort of behavioral-based treatments, but you can think of something that I find is powerful with some patients, is to say it's just like exercise. Exercise is repeatedly doing the same thing over and over to tone up your muscles so that they will function better when you need them to tomorrow, right? CBT is exercising your synapses over and over, strengthening the ones that are positive and conduce to adaptive brain functioning, and perhaps weakening the ones that are negative and conducing to symptoms so that it'll be in better shape and function again tomorrow. And again, when people have a biological or a materialist conception of the world and of what they're experiencing, I have found this a very powerful way to get them to accept psychological modes of intervention. And I think that this is a powerful tool. How about the other way around? So what if someone is conceptualizing their symptoms and their experience in purely psychological terms? Okay. Well, some of the same, then why would they be interested in psychotherapy? I'm sorry, in pharmacotherapy. They may be interested in what I just said about psychotherapy. That may give them a new way to understand it. They may not care, but they're still going to be invested in psychotherapy. How does that help them understand pharmacotherapy? Well, if both their experience and psychotherapy is real and true and genuine and a powerful way of explaining things, and is related to information processing in the network that is the brain. The network that is the brain can be modulated by drugs. It can be modulated, but not just by drugs, by biological state. So our mood, our energy, our behavior, our network is modified by caffeine. It's modified by alcohol, right? These change our behavior and our emotions and our thoughts by changing the information processing in the network, right? So it's not a big leap to say the same thing can happen with medications. That isn't to say that it's not about psychological phenomena. That's to say that we can nudge the psychological phenomena in a healthy way using medications. Can we also harm the processing of information using medications? Yes, of course we can, and there's plenty of examples of that. And so that's why we need to be careful and use things that we have reason to believe will help and are proven with studies, and we need to pay attention to, all of that. But I have found this a way to try to introduce people who have a psychological concept of their disease to the idea that medications may be a helpful adjunct to treatment. And I've had cases where this has broken down resistance and led to more improvement. So I think that this, thinking about things in the brain and practicing a language to explain them in this way to our patients can be of concrete help in our ability to deliver care today. Okay, so now I'm going to get a little bit more technical, though again, I'm just going to put up specific examples to illustrate the points. I'm not going to go into any of the examples I'm putting up. I'm happy to dive into the details for as long as you want, but that's not my plan for the purpose of this talk. And this is what I'm going to talk about in terms of brain stimulation. So brain stimulation, the oldest type of brain stimulation is ECT, right? ECT, you zap the brain. Actually, maybe even older is insulin shock therapy, insulin coma therapy, but we'll skip that one. So ECT, extraordinarily effective in appropriately chosen cases of catatonia, of depression, of psychosis, probably underused, has side effects, shouldn't be used lightly. doesn't really require you to know much about the brain, right? There's very little anatomical specificity. The function isn't that important. You just put a couple paddles on, you zap, and stuff happens. And you need to know more about, anesthesia and about, managing the motor, seizure and so forth than you do about the brain. So that was true until fairly recently. But now we have several different, well-proven, approved forms of transcranial magnetic stimulation, or TMS. I don't know how widely that is used in Brazil, but it certainly works. It works in depression, it works in OCD and other things. But it's not the same as ECT. I have people say, well, I will just get TMS. And I'm like, okay, that's like saying I'll just go get drugs, right? Or I'll just go get therapy. What kind of TMS? Where? How? These things start to matter in a way that they matter much less with ECT. I'm aware that there are parameters that you adjust with ECT, but they're fairly simple, right? There's just a few parameters to adjust. With TMS, there's a lot of parameters to adjust. And in order to think about how you're going to adjust them, you need to think about where in the brain am I stimulating? What goal, what am I trying to achieve? Why does doing it repeatedly matter? Understanding the processes start to matter a lot more. Now, can you get away without it today? Yeah, because most of us don't do TMS. Most of us refer someone to a specialist for TMS if that's what we're going to do, and that's fine. But I think that knowing when to refer, being able to hear back from that specialist and have a sense of what was done, knowing if the specialist is wrong, I'll give you an example of that. I think that being conversant with the mechanisms and what's going on really is important today to be a well-trained psychiatrist, in a way that it wasn't previously. The example that I was going to say, so the oldest form of therapeutic TMS involves using a figure of 8 coil to do shallow stimulation in the dorsolateral prefrontal cortex, either bilaterally or on the left side for depression, okay? Repeatedly, typically for like 30 sessions. It's long, inconvenient, and it can work. For a while, that was what TMS was, right? Outside the research context. So then that was tried in OCD, right? And it doesn't work. Then they tried using the same coil in the midline, and it works a little in some studies and not in others. Then they developed a new coil, which allows the fluctuating magnetic fields to penetrate deeper into the brain and thus give some stimulation to the anterior cingulate cortex and the medial prefrontal cortex. And that seems to work for OCD because it's targeting the brain regions that we think are pathologically affected in OCD. Okay? So I just threw out a lot of neuroanatomy terms that we need to be familiar with. We need to be able to explain to our patients. And I've had plenty of patients go to TMS, say, I got TMS for my OCD, it didn't work. And I say, well, what did they do? They zapped my brain over here. I'm like, no, that was wrong. That's like saying I need I was treated with an antipsychotic and it didn't work. What did they give you? Gabapentin, right? It's a misapplication. And unless we know the language and unless we can we can think about that, then today we're not optimally positioned to treat our patients. Obviously, I think that's going to become much more true over time. I think in 10 years, we'll probably have 20 different ways of doing TMS, perhaps individualized TMS, which people are starting to do in research settings where they do an EEG in order to find the appropriate locus of stimulation, and then they target stimulation to that precise point. So what is true today, to a real but small extent, is going to become increasingly true going forward. For example, there's some research doing, instead of stimulation here at the top of the head to try to get to the deep structures in OCD, there's some research stimulating the orbitofrontal cortex above the eyeballs. It seems to work pretty well. Why? Because the orbitofrontal cortex is hyperactive in OCD. I'll show you an image of that a little later. And so we can modulate it. So that's a place where understanding the biology, understanding the pathophysiology has led researchers to a new mode of treatment, which might get out there for clinical use in the near future, because it's not hard to do. It's the same machine. You're just poking a different place, right? It's actually quite painful because the frontalis muscle contracts. So that's the main problem. But this is another place where I think understanding what's going on in the brain matter. Now, here's another example. This isn't quite ready for clinical use, but I think is very exciting and I think will be soon, and that is this. Can brain stimulation enhance psychotherapy? Well, going back to what I said about thinking of the brain as a network and the key aspect and the central role of synaptic plasticity and psychotherapy as learning, right? Well, that means that psychotherapy is changing the network by means of synaptic plasticity. And if we could find a way to enhance that change, we could make psychotherapy work better. In my mind, actually, this is one of the great frontiers in psychiatry, because I don't know that we're going to get dramatically better with meds than we do today. We can get smarter and use them a little better, but they're never going to be fix people. And psychotherapy, I think we will get incrementally better, but I think actually there are good expert psychotherapy now. It's pretty good. The problem there is mostly a health systems problem of getting good therapy to the right people. But if we could combine the two, we may be able to break through, have briefer therapies work better by using brain-targeted manipulations, be those drugs or brain stimulation or something else, in order to enhance the psychotherapy. Another way to think about that is that the brain-targeted manipulations are relatively crude. You know, drugs go everywhere. Stimulation hits at least a big chunk of brain. Psychotherapy is very precise, but kind of indirect and slow. If we could combine both, that I think is a real frontier for enhancing the efficacy of our treatments. And here's an example of that. This is done by my colleague Tom Adams, who worked with me as a postdoc and is now a faculty member at Yale. And what Tom realized is that cognitive behavioral therapy for OCD is of a very specific type, probably familiar to many of you, and is based on the idea of extinction learning. So not just any kind of learning, but extinction learning. And extinction learning is the idea that you have someone with OCD, and the same applies to many other forms of, phobia, PTSD, anxiety disorders more broadly, that you have an association in your brain that says something is dangerous that really it isn't, right? It's like a fire alarm going off when it shouldn't. And that leads to a constant state of feeling in danger. This is a way to understand anxiety disorders. Extinction learning is learning that something that you thought was dangerous is actually safe, okay? It isn't forgetting that you thought it was dangerous. It's learning that it isn't dangerous. It's not erasing the belief or the memory that it's dangerous, but rather overlaying it with a new memory that it is safe. So this is the generally accepted model of how CBT for OCD, as well as phobias and some other conditions, works. And it's something that we know a lot about from animal studies. You can make an animal afraid, you can make an animal less afraid through extinction learning. And I could spend a lot of time talking about the experiments and the circuitry. There's decades of really exciting work in animals, some of which has then been extended into people. And what you see here is some of the circuitry that is involved in extinction learning. So this region of the medial prefrontal cortex, this region in the cerebellum, a little bit of the anterior cingulate cortex. These regions are involved in extinction learning, as is the amygdala, which you don't see in this sagittal brain section because it's off to the side. And specifically, it's projections from the medial prefrontal cortex down to the amygdala that are thought to be enhanced. Plasticity at those projections is thought to be essential for extinction learning based on animal studies. This study here from Malad and colleagues a decade ago is testing that in people with OCD, and they found that people with OCD are bad at extinction learning. The brain, we knew they were bad at extinction learning. They found that they also recruit the brain structures less well. So that led Tom to come to me with the idea that we developed together that maybe if we could target this circuitry, if we could do something to this circuitry to make it work better, to enhance its capacity for plasticity, maybe we could overcome this deficit in extinction learning and make therapy work better in OCD. And we did this with a technique called transcranial direct current stimulation. Could have done it with TMS, which is transcranial magnetic stimulation. But we didn't. We did it with transcranial direct current stimulation. This is a very simple thing. If you take a battery, take the anodal wire and put it on your forehead and the cathodal wire and put it here, and you feel a little tingling as the current runs through you, that's transcranial electric. Now we don't actually use 9-volt batteries and wires. We use a slightly more sophisticated apparatus, but that's the idea. You're passing a low amperage current through the brain because neurons work on electrical, using electrical signaling that alters their properties, and that causes, if you do it properly, and again, a lot of detail that I won't get lost in, or I'll try not to, but that causes the brain to become more responsive and have a higher capacity for plasticity for a period of about an hour after 20 minutes of stimulation. So that's what we did. This is an illustration of the stimulation, anodal stimulation here on the frontal pole, several cathodes around the outside, which allows the area of stimulation to remain very focused right here. And then Tom did a bunch of studies. He did some neuroimaging. I'm not going to go into all those details. The important one is he did this with a bunch of people with OCD. And half of them got real stimulation, and half of them got a sham stimulation, where they got the same electrodes and they had just enough stimulation to give them a feeling that something was happening, but then it was turned off. So they didn't get stimulation. It was a placebo. And then all of them went through a session of ERP, of the extinction-based therapy for OCD. Okay, one session, 1 hour, not a full therapeutic course. And every minute during that hour, he said, so the way ERP works, for those who don't know, is you identify something that the person finds aversive. So somebody who has contamination symptoms with OCD, you might have a bedpan or a dirty towel, right? And that's a stimulus that's going to make them anxious. And this is picked individually for every subject. That's part of the art of it. And then you expose them to that, and they get anxious. And then you just sit with them. You don't let them engage in compulsions. Don't let them go through that feedback loop that I was describing, but rather let them sit with the anxiety as it comes down, which it will. Which is an odd experience, because it's like, why would, if you feel awful and you know how to fix it, why wouldn't you fix it? That's why people don't. But in therapy, that's what we do, and that leads to extinction learning. Okay, that's what we do. So he did this 5 times in an hour, and every minute he said, how anxious are you right now? Okay, I'm giving you all the background before I show you the data, because as soon as you see the data, you're going to know the punchline. Okay, can you guess which group got the real brain stimulation? So this is over the course of an hour, 5 exposures, measures every minute. The y-axis is SUDS, subjective units of distress. It's how anxious you're feeling right now. So the folks in blue had this standard session of extinction-based therapy for 1 hour after sham brain stimulation. Now, they didn't know it was sham, and the person who was doing the extinction therapy didn't know it was sham. The person who was operating the zapper knew it was sham, but they weren't in the room. So that person had a little bit of slow extinction over the course of an hour. This is about what we would expect in one session, the first session. But the people with the TDCS, which led to, we believe, alteration in the capacity for plasticity in the medial prefrontal cortex and its projections down to the amygdala, had a dramatically increased rate of extinction. Okay? We have not done this yet with a whole 8-week or 12-week series of extinction to see if it has a lasting clinical benefit. That obviously is the direction that we would like to go. And we didn't get the grant yet, so we're working on that. But if this works, so the hat we use costs a couple $1,000s. Probably, if we're a specialized one, could get it cheaper. A therapist could have that in their office. In the waiting room, people sit with a hat on their head to prime their brain for benefit. And if you could get this much benefit on the first trial, the first session, people are more likely to come back to the second. So you're going to enhance retention. And hopefully you get people better faster too. You're going to enhance efficacy. Right? So I think that this kind of thing has great potential, and it derives entirely from an understanding, or at least a theory, of the underlying neuroanatomy and mechanisms. So, on the horizon. Here's another thing that's on the horizon. This is a study I've been working on. It's been actually 10 or 12 years we've been doing this work with my colleague Michelle Hampson, who's at Yale. It's neurofeedback. And here's the idea. So again, in OCD, that's the only thing I know anything about, OCD is associated with hyperactivity of the orbitofrontal cortex, shown here in the sagittal MRI section. So when people at baseline, if you just put people in a PET scanner to measure baseline activity of their brain, people with OCD have hyperactivity in the orbitofrontal cortex. And when you treat people, that hyperactivity goes down, right? And there's a few other reasons to think that this actually matters, that it's not an epiphenomenon, that it's central to the pathophysiology of the disorder. So the idea that Michelle had, and that we've developed together, was to use neurofeedback to change this activity. What is neurofeedback? Well, it's a form of biofeedback. Biofeedback is when I measure something about your body that you normally don't have conscious awareness of or control over. Like your heart rate, like most of you couldn't tell me right now what your heart rate is. You can sort of try, but or feel your pulse, but you don't have ready conscious access to it. Or how much you're sweating, or some other aspect of your body that you don't have conscious access to. And then, so you measure it, you show it to them on a monitor, and that's the feedback part, and then they learn to control it. So people can learn to control aspects of their physiological function that they wouldn't otherwise be able to, presumably through plasticity in the network. But, so that's biofeedback. Neurofeedback is the same thing, except instead of your heart rate or how much you're sweating, we measure something about brain function. This has been done with EEG. We did it with fMRI. So we put someone in the magnet, and the fMRI magnet, and we measure the current activity of their orbitofrontal cortex, okay? And then we show them pictures, either neutral pictures or pictures associated with their OCD symptoms, contamination, checking, whatever. And then while the pictures are on the screen, we ask them to either increase the activity of their orbitofrontal cortex, or decrease it, or leave it the same. And at the beginning, they have no idea what we're talking about, right? This makes no sense at all. But we show them this measure, the current activity. So this line at the bottom of the screen, this is exactly what they see while they're lying in the magnet. The white arrow means relax, don't do anything. A red arrow up would mean increase your orbitofrontal activity. A cyan or blue arrow going down would be decrease your orbitofrontal activity. So we show them that. And what you see here is the activity of a very successful subject's orbitofrontal cortex while they're doing this over a period of about half an hour. Okay? And you can see that this subject successfully learned just through trial and error and then getting feedback of when they were successful to increase their orbitofrontal cortical activity when they were instructed to, and to decrease it at other times. Okay? That's pretty cool. I think it's astonishing that people can do this. People can do this. Does it make any difference? So our first study using this technique was with people who didn't have OCD. They had contamination. They didn't like yucky things. They had contamination phobia. Some of them probably did have mild OCD. We didn't thoroughly clinically assess them. But undiagnosed, untreated, we put them in the magnet, and we gave half of them this neurofeedback that I've just described, and the other half we gave sham neurofeedback that felt to them exactly the same, but didn't in fact give them any useful feedback about their brain signals. They weren't learning anything useful, okay? They didn't know which group they were in. And then after sessions of neurofeedback, we said, okay, here's a yucky picture, how anxious does it make you, right? And the people, what's shown here is how much that changed in the people who got biofeedback. This is on a scale of 0 to 5, so there's a modest 10% reduction in how anxious these images made them, versus the people who got sham feedback, no change at all. People did not know which one they got, right? So, and this was statistically significant, and it was associated with some changes in brain wiring that are really cool, that's a different talk. So seems to work. So this got us a grant to go on and look at this as a treatment for OCD. So we did the same thing in people with OCD, and we tested them not just how uncomfortable does this picture make you, but with their symptoms judged by the Yale Brown Obsessive Compulsive Scale, or Y-BOX, and this is what we saw. So immediately after treatment, there was very little change, but then over time, there was an increasing improvement in the people who got the real neurofeedback compared to the people who got the sham neurofeedback. Okay? 3 conclusions from this. The first is it worked. We got a separation from the groups, and it does seem to make people better. The second is the effect is disappointingly small. This is about a 1.5 point drop in the Y-BOX. It's a statistically significant effect, but not a clinically significant effect. So we're now thinking about we proved that it worked. That got us a paper. How do we make it better so that it can get us to help people, which is the goal. That's point 2. Point 3 is it happens slowly. The neurofeedback is over at this point. So what I was expecting was that the people would get better immediately after, and then that improvement would decay. What we see is the opposite. Very little, if any, improvement right after, but then this benefit that increases. And there's 2 ways to think about that. One is that people have learned skills to manage their distress, and they're practicing, whether they're conscious of it or not. They're practicing it, so they're getting better over time. The other, which isn't mutually exclusive, is just using a neurophysiological language, is it may be that we've set up synchrony between networks that wasn't there before, which leads to an ongoing accrual of synaptic plasticity and a growing reorganization of the networks over time. Okay? I think these are both probably true and are maybe even the same thing, but those are my theories. But anyway, this is, again, not ready for prime time. Right? It's not in treatment yet, but it's pretty close and it's pretty easy. Now, the magnets are expensive, so exactly what we're doing here would be difficult to roll out into widespread clinical practice, but it's a direction when we're thinking about how do we make this work better. All right. The other thing on which I'm not going to show data is deep brain stimulation. So deep brain stimulation, as you all know, is when we put an electrode into affected structures in the brain in certain conditions, most developed in Parkinson's disease, but now being researched in OCD, where the data are quite good, and in depression, where they're mixed and we haven't got quite figured out yet, and in other conditions. There's a study going on right now in addiction. And the idea is that you can modulate brain circuits by appropriate stimulation. Now, this is not something that your general community psychiatrist or even most academic psychiatrists are ever going to be doing in their office, right? It's a very, very rare, worst of the worst refractory cases specialty intervention. But it is something patients come and ask us about. And so once again, what are the circuits? Where are we stimulating? Why is that helpful? These are things that I think we need to be conversant with today, and more so going forward. Okay. So that's my overview and a few ideas about why understanding about the brain is useful and maybe even increasingly essential for clinical practice today, for us optimally engage with our patients. I'm now going to hit just a couple things, and I'm going to go a little faster here because this is more speculative, but a couple things about, and also because I want to give Yuri lots of time to discuss, about things in the future, things that I anticipate will be relevant in the years to come, although they're not quite on the horizon yet. So the first is new ways to diagnose or think about psychiatric disease, okay? This, in what's probably an unfamiliar form, is the DSM-5. This is every diagnosis in the DSM-5, organized by the chapters, right? Every single one, there's, what, 237 or something like that, all right? It's a ridiculous mess. These are not diseases. These are not distinct entities with a clear cause and a unified treatment, right? It's a description, okay? So one way that I think advancing knowledge of the brain and of other things, and of symptoms and social causes and so forth, will help us move forward is to help us develop new and better languages to explain, to explain and think about and categorize and communicate about the illnesses or the symptoms that plague our patients. And there are other options out there now. The National Institutes of Health developed the RDoC framework. It's not intended for clinical use, but rather for research use. So I don't think it's as relevant, but there's one that may be less well known, but I think is really promising, that's developing, called HiTOP, which is a hierarchical taxonomy of pathology. This just came off the web. You just Google HiTOP, you'll find it. And the idea of HiTOP is that we shouldn't be thinking about our disorders as discrete entities in the way that we think of a broken foot and pneumonia as discrete entities. We should be thinking them in a hierarchy of dysfunction. And a key insight is that there's this thing at the top called the general factor, the general psychopathology factor, or the P factor, which comes from the insight that lots of people who are sick, who are struggling psychiatrically, often have a lot in common. A large portion of the variance of people who are struggling with psychiatric symptoms is shared across different diagnoses. And then you divide that out into internalizing disorders, externalizing disorders, and a few others. And then underneath those, you have, eating pathology, anxiety, sexual problems, fear, distress, etc. So conceptualizing the different domains of psychopathology in a hierarchy rather than as discrete kinds, and then thinking about how an individual falls within that hierarchy. The way that this has been developed is not based on brain science, but it is very data-driven. What they've done is they've taken, and what they as a nonprofit collaborative group of researchers, this is kind of a grassroots, built from the ground up kind of way of addressing it, as opposed to RDoC, which came from the NIH, and DSM, which came from the American Psychiatric Association. This is more grassroots. And what they've done is they've taken lots of symptoms, and they've just looked empirically using clustering algorithms and statistics at how they cluster together, and this is what they came up with. So this is still symptom-focused, not brain-focused, and it still doesn't incorporate things like development and social perspectives particularly effectively. But it's a really interesting step in the right direction. And I put it here just to illustrate that there are alternatives to the DSM. And it will be hard to replace the DSM because it's so baked into our system, including governments and insurance companies and medical coding and all of this. But it will happen, and this is one interesting direction. Imagine if we could bring all the streams of data into this, including brain-based data, in order to get to categorize our disease. And I emphasize that in saying this, I'm not saying that all of our diseases are caused primarily by things that were originally brain pathology, right? They could be caused entirely by environmental pathology, but they're going to be reflected in the brain. There's going to be information there. And because some of our treatments, work through the brain directly, well, I would say all of our treatments work through the brain, but some of them very directly, that information is very likely to be helpful. If we could incorporate that into our diagnostic system, that could lead to a major advance. And an example of this is the BSNP initiative. BSNP is the Bipolar and Schizophrenia Neurophenotype something program. And it's a collection of research. One of the sites is my colleague Godfrey Perlson at Yale, but also Carol Tominga in Dallas and various other sites, I think all in the United States. And what they've done is they've recruited, they had the idea that we have people, if you look in this figure, we have people who are diagnosed with schizophrenia, people who are diagnosed with schizoaffective disorder, people who are diagnosed with psychotic bipolar disorder, or for that matter, psychotic depression. All of these people have in common psychosis, right? They're all experiencing psychosis. What if instead of diagnosing them with these individual DSM entities, we diagnose them with psychosis? And then measure all sorts of stuff. They measured MRI and EEG and questionnaires and skin conductance and self-reports and everything they could think of to measure. And then look in all of those measures to see if we can divide these out into what they call biotypes that are more homogeneous, that are more internally consistent than these disorders, schizophrenia, schizoaffective, I mean, especially schizoaffective disorders, this ridiculously heterogeneous grab bag, right? What if we could use the biological information to identify more homogeneous clusters? And they did that. Starting in 2016 in a long series of papers. And this is showing how they took all of their people with psychosis, and they found that if, this is actually based mostly on EEG data, was how they did this clustering, but they've used lots of different analyses. And they found that if they measured people in two different dimensions, one is their ability for cognitive control, and the other is their reactivity to sensory stimulus and tendency to startle. And again, these were measured using behavioral tasks in EEG. Then people fell out into these three overlapping but fairly distinct clusters, which are biotypes 1, 2, and 3 are shown here. It turns out that these biotypes differ from one another in a lot of ways, which again, I'm not going to go into all of the details. It turns out that they have nothing at all to do with diagnosis. So if I look at schizophrenia, bipolar, and schizoaffective disorder, they're scattered all over the place. They do not cluster with the biotypes. So they are a new way of clustering and thinking about it. And they are in the process right now of testing treatment to see if the biotypes respond differently to pharmacotherapy. That's still in process, and I do not know when we will have a readout on that. Is this the right way to categorize psychosis? I don't know, but it is a way to categorize psychosis, and it is based on measures of brain biology. So I do think that in the future, just as you would not, you wouldn't diagnose a particular heart condition or arrhythmia without an echocardiogram or an EKG, right? And you wouldn't diagnose a particular form of tumor without an MRI or some other form of imaging to look at it and maybe take a piece of it. Having biological information to inform our diagnoses is never going to replace understanding our patients and connecting with them and understanding their symptoms. It's never going to replace a knowledge of the environment in which they function, because all medical conditions are influenced by environment, but our conditions much more so. It won't replace those. It will supplement and augment, and we need to be ready. How about new diagnostic tools, right? So if we have new ways of thinking about disorders and perhaps new treatments, how are we going to figure out which person is going to respond best to which treatment? Well, our diagnostic tools aren't ready for prime time. There isn't any brain imaging today that is useful for psychiatric illness, with one exception that I'm going to get to. But they are advancing very rapidly, and this too, I think, will become important in the years to come. So some of you may have seen this image. This is figure 1 from Leonardo Saraiva's PhD thesis, which he brilliantly defended yesterday, and is really cutting-edge analysis of brain structure. I'm not going to go through the details here. This is comparing people with OCD on or off medications to people without OCD, and saying where different ways to measure brain structure differ between OCD and the rest. Doesn't matter. This is just to say we're getting really good at analyzing brain structure in lots of different ways. And this will, I think, inform clinical care in the future, although it doesn't yet. Same thing with functional MRI. So this is an fMRI scan, same image I showed earlier. This is from I just picked because it was convenient from a study I did with Alan Antisevich just 10 years ago, looking at functional connectivity within the brain. I'm not going to take the time to explain what functional connectivity means, just suffice to say that it's a measure that we can derive from fMRI, from functional MRI, which tells us about the informational organization of the brain, which parts of the brain are communicating with others. And it differs in different psychiatric conditions. That's what's shown here. We're doing a test right now to see how it changes with treatment. And this kind of thing. Resting state at functional MRI is being used by radiologists in clinical settings, mostly to plan neurosurgical approaches, but it is being used clinically. And I think it's only a matter of time before we are able to use it to help clarify psychiatric diagnoses. There is one instance of imaging, brain imaging, being used for diagnosis today, and that's in Alzheimer's disease. So there's been decades of work trying to understand the pathophysiology of Alzheimer's disease with frustration after frustration after frustration for 30 years until just a couple years ago, when the hypothesis that's illustrated here bore fruit. And what's shown here is the accumulation of amyloid, which is a pathological misfolded protein, the A-beta protein that builds up in people with Alzheimer's disease. What was shown a couple years ago by a bunch of investigators led by Chris Van Dyke at Yale is that a new drug, an antibody that can clear amyloid, can slow the progression of Alzheimer's disease. But to use that drug, which is super expensive and requires an infusion, and you don't want to just use it on anyone who's having a forgetful day, right? You need a clear diagnosis. We need to know if there's amyloid in the brain to be targeted, and that we can do with PET imaging. So PET imaging is now used in the diagnosis and treatment planning of Alzheimer's disease. So this is the first hint that this is going to become relevant for treatment of psychiatric patients or neurological patients. I know whether Alzheimer's is a psychiatric versus a neurological disease depends on what medical system you're in, but I think it illustrates the point that as our understanding of brain biology and pathophysiology advances, these tools will become more. Now, how do we interpret them? Here, there's another series of advances, which is machine learning and artificial intelligence to make sense of these things. I don't think that there's something in the brain like if the amygdala's a little bigger, then you have a generalized anxiety disorder, right? If it was that easy, we would have known 20 years ago. It's not going to be that easy. The alterations, be there in PET imaging of function or fMRI of activity or structural imaging of shape and size, they're going to be subtle and they're going to be distributed. We need new information processing strategies in order to try to assess those. That's what's illustrated here by Amanda Buch, who's at Cornell. I just had the pleasure of hearing her present these results the other day, and I thought I'd tell them. The details don't matter, and honestly, I don't understand them. But what she has done is taken a new iterative way of taking very complicated data, of any kind of data, be that genetic or brain structure or brain activity or anything, and finding the hidden structure in it that lets you tease apart clusters that are different from one another, but in a way that isn't remotely obvious to the naked eye. It requires algorithms. So I just put this up there to illustrate that this is another place where advances will come along. I don't expect most psychiatrists to become, the developer of new algorithms or to understand all the mathematics behind them. I certainly don't. But to understand that they exist and how to deploy them and be able to call on expertise at need, I do think will become important as we begin to deploy these new strategies. All right, how about new drugs? Well, this is new therapeutics. This is pretty obvious, and so I'm not going through specific examples. But of course, lots of academic centers and lots of drug companies are continuing to try to develop new drugs, and new ones that are either brand new or are on the horizon are, first of all, psychedelics. There's a lot of attention on those. Those may change practice. Xanomeline is the new non-dopaminergic antipsychotic that was proved to work and was FDA approved in the United States by last fall. I don't know if that's in use here, but it's the first non-D2, non-dopamine acting antipsychotic drug that we've had ever. So that's exciting. Allopregnanolone, which is used for postpartum depression. It's a neurosteroid and is used for postpartum depression. That is available. So there are new drugs these aren't just new SSRIs, right? These are fundamentally new mechanisms of action. Those are coming along. I talked a little bit about brain stimulation, how TMS is going to different places. Two other things that are a little further on the horizon are focused ultrasound. So it turns out that you can activate or inhibit parts of the brain, including deep inside the brain, with sound waves by focusing them in just the right way, which is pretty exciting, not in clinical practice, but something that's in research now, and I think has a lot of potential. Because then, if we do that, we don't need deep brain stimulation anymore, right? Which would then lower the bar for doing a deep brain stimulation strategy for treatment if it didn't require neurosurgery, but rather could be done with a helmet. Responsive neurostimulation, this is the idea that you record what's going on in the brain and use that to determine your stimulation. Rather than stimulating all the time, you only stimulate when needed. This is already being done in epilepsy, where electrodes will recognize when a seizure is about to happen, and then the stimulation will stop that seizure before it starts. It's obviously done in cardiology. This is what an implantable defibrillator is doing, is it's recognizing when arrhythmia develops and then delivering a shock to try to neutralize that. I think that will be a new frontier. And if you combine that with invasive stimulation with TMS or focused ultrasound. So it does, because we first do this with DBS. But if you combine that with non-invasive stimulation, and especially if it's non-invasive stimulation that only has to happen once in a while, not continuously, then suddenly that could open a whole new frontier in treatment. And of course, I talked about pairing of brain stimulation with psychotherapy. This is an area I'm very excited about. Can we take two things we already know how to do moderately well and combine them in an intelligent way to make qualitative advances? And of course, I'm very focused on the brain in this talk because that was my topic. But not only combining brain stimulation with psychotherapy, but also developing a deeper understanding of the environmental, social, developmental causes of our disorders and figuring out how to integrate across different levels of analysis, but also different levels of intervention in order to get maximum benefit. These are what I see as frontiers in the coming years. And finally, and this is a little bit parallel to what I was saying about the categorization of illness, but a deeper point is how do we think about what psychiatric illness is in the first place, right? I mean, we don't have a very clear conception of that, or rather we have a bunch and they're kind of muddied, and we have you can go to two different people and get completely different explanations, even if they agree on what the diagnosis is of the underlying etiology. We have a lot to learn and a lot to develop about what it means to have a psychiatric condition. Is disease the right term? Is diagnosis the right way to think about it? Or should we be thinking about, continua or interactions between or other things that are beyond diagnosis? That's not such a weird idea. I mean, obstetricians treat things that aren't diagnoses all the time. Maybe they are in the medical record, but they're not illnesses. A broken knee isn't a diagnosis in the same way pneumonia is a diagnosis, right? Different medical, different aspects of dysfunction and suffering require different explanatory frameworks, and I don't think we know the right one for psychiatry yet. And I think that many lines of investigation, including genetics and including social determinants and including a better understanding of development and stress, but also including brain biology, will feed into this understanding. And it won't necessarily be the same for everything that we call a psychiatric disorder, right? I don't think there's a holy grail of one way to think about it which will make everything simple. I don't think it will be simple. I think we need to embrace that complexity. And what I'm illustrating here from my colleague Aaron Alexander Block, who trained at Yale but is now at the University of Pennsylvania, is a growth chart of the brain. So when you go to your pediatrician in America, and I suspect this is universal, you get a growth chart. You measure the height and weight of the child, and you see where they are, and you expect them to follow the curve that corresponds to their percentile. And if someone is 60th percentile and stays there, that's fine. And someone else is 10th percentile and stays there, that's fine. If someone is 60th and then starts to fall off the growth chart, they may fall to 10th percent, which would be fine for the other kid, but this kid, something's wrong, right? So these growth charts are essential to understand growth. Well, this is a growth chart for the brain, and it's measuring different measures that you can get from a structural brain MRI scan from birth up through old age, and plotting how, what a normal growth chart would be. And Aaron is developing, based on thousands of brain scans, more and more sophisticated growth charts. Well, maybe one way to think of psychiatric diagnosis or psychiatric disorders is a dyssynchrony in growth. Right? Suppose that your frontal lobes were just a little younger than the rest of your brain. They were a little delayed. That's probably going to have functional consequences. Maybe we could think of psychiatric diagnosis as dyssynchrony of normal developmental processes, or disruption. I mean, don't have to, the dyssynchrony is a subtle effect. Maybe they're totally disrupted, and the brain is younger than it should be or disorganized, right? This is a different way to think about diagnosis, not as it broke, or even as it never developed properly, as we might in a neurodevelopmental disorder, but rather it is, the different parts are all developing properly, but they're a little bit out of balance, they're a little bit out of whack, and that's causing the system as a whole to not function as it should, right? That concept of diagnosis would certainly have a different implications for how we think about illness and how we communicate about it to parents, to patients. It might, you could imagine, have implications for treatment, right? Suppose we had a brain stimulation that could accelerate the growth of a particular portion of the brain, like you can use a bone stimulator to help someone grow. If a child is pathologically delayed in growth, you can use a stimulator. Maybe we could do that in the brain. Maybe we could have someone wear a portable stimulator cap for 6 months, so their frontal lobes can catch up with the rest, and now lo and behold, they're imbalanced. That's totally science fiction at this point, but it's why this matters. So what I'm illustrating here is brain connectivity. I told you that fMRI can be used to map the exchange of information between different parts of the brain. And that's shown here on the left is a sort of a cartoon of a brain with the lines showing the strength of connection, functional connection, information exchange between different parts of the brain. On the right is the same information, but it's sort of shown in a graph form where every point around that circle is a piece of brain and the lines connecting them are the strengths of the connections. The details don't matter. My point here is that everything I just said about brain structure, we could do with brain function. And we actually do know how to, we know how to analyze this. We can find differences between groups. We can't yet use this to diagnose or to refine diagnosis. But for example, maybe there are 2 or 3 different kinds of OCD. Maybe there's OCD that is characterized by excessive information locking between the default mode network and the amygdala, and another one that is characterized by a loss of normal desynchrony between the default mode network and the salience network. Okay, those actually were coherent hypotheses that I won't dig into. But this would be another way to think about illness. And these changes could come from an environment or experience that cause different networks to become more linked together. And they could also inform therapy. We do know how to increase or decrease the linkage of networks through brain stimulation, although not in ways that are clinically relevant at this time. Finally, I've mentioned a couple times the importance of the environment. I was using AI a little for a couple of these images, because but I've mentioned a little bit about the environment. We've gotten very good at measuring the brain. Need to get better? We've gotten very good. We've gotten very good at measuring genetics, like really good at measuring genetics. And that has focused a lot of research on those areas. We're not very good at measuring environmental events. We don't really know what to measure. And most of the environmental events, by the time we see our patients, happened in the past. The brain is there in the office and the genetics we can get. The environmental events mostly happened in the past. And most people are terrible at narrating retrospectively the important details of important events, especially going back to childhood. So we don't have ways to measure environmental events, and that has made it much harder to integrate them into our models of pathophysiology, except in rather broad or crude ways like, abandonment, or cigarettes, or, their toxic lead exposure. There are these big, crude insults that we know those effects, but those are probably not going to explain most of most people's conditions. So we need to get much better at this. And this too, I think, will inform our conception of psychiatric illness. Currently, our conception of psychiatric illness tends to be dualist. It tends to be either mind or brain, just like our patients. And when we're thinking about psychological explanatory models, we tend to be completely in the realm of abstractions. It can be very useful to reach a diagnosis or to plan therapy. I'm not belittling this. I'm saying it's incomplete. And the same is true of a brain-focused interest of, a concept of psychiatric diagnosis. And frankly, the same is true of a narrow developmental focus. If you say you have psychiatric symptoms because you were abandoned at age 3 and grew, but say nothing at all about genetic susceptibility or about current environment or about psychological support networks, then you have an inadequate understanding. So I think that that integrating these levels will fundamentally change how we think about psychiatric illness. And I think the biggest challenge is to better understand environmental effects during development, because we don't have the language and we don't have the ways of measuring them at the level of resolution that we have developed for brain and for genetics, and to some extent for psychological metrics. We don't have this for things that happened long ago. And this is something that I think will be increasingly important going forward. I'll end on that note. Everyone, work on knowing your brain. Take good care of it. And I appreciate your attention. I hope that this has been interesting, and I look forward to Yuri's comments and to some discussion. But then everyone will be looking at me.
Thanks a lot, Chris, for this wonderful lecture, for being here, and for all your investment in our department, taking care of several of our students. More recently, Ilana, Leonardo is there, and hope after this encounter, we will have more of our residents going to Yale and meeting and interacting with you. In fact, David is here. David is going to Yale. You already met him yesterday. And Laura is here. Laura is both of them. I need you to help me to take care of them where they are there, Chris. But
I'll show them all the best pizza.
oh, yes, great. Over. That's great. I find your talk very interesting, encyclopedic. I thought very interesting, and so maybe instead, as I will comment, I'd like to make one question. So I don't know if you guys know, but he mentioned during his talk that he was training with Eric Kandel. Eric Kandel was his first advisor. Eric Kandel, for me, is one of the most interesting persons in psychiatry. And what I admire him mostly is his ability to integrate knowledge, and deeply integrate knowledge, right? And from psychoanalysis, psychology, basic science, psychopathology, and I see some of his this ability to integrate knowledge on you as well. So I would like to know, to tell to our residents how your training with him impacted in your education and your knowledge, and also the importance of having this experience in basic science that you have. So Chris has also a basic science lab, and the translational research in your life. How does it improve your knowledge and the way of conceptualize psychiatric disease, for instance?
Sure. Well, so your first question for Eric Kandel. So I worked with Eric kind of by accident. I was telling the residents earlier how many things in my career have been by accident. This was another one. Eric Kandel, you may know, he started studying in the 50s and then to the 60s with Ladislav Talk in France. And Talk was studying aplysia, which is a sea slug. And the nice thing about aplysia is it's got these enormous neurons, like up to like a millimeter wide, which means that using the technology of the day, you're able to record from neurons and make observations that you couldn't otherwise because the technology wasn't there. And Kandel's great insight was that he wanted to study synaptic plasticity, and everything I said about synaptic plasticity as being the locus of interaction between the world. It's the way the world influences us, or it is a component of the machinery whereby the world influences us, and then that changes our behavior, and thus we influence the world in this constant lifelong spiral of influence. So he recognized that as something to study because it would help understand psychoanalysis. I mean, really, that was the motivation. And the aplysia made sense because of the technology. I did not want to study slugs. So when I went to Columbia, Kandel was the god of neuroscience at Columbia University, but I didn't plan on trying to work with him because I had no interest in studying slugs. But I was at a lecture that he gave one day, and I went up I'm a 22-year-old excited neuroscience student sitting in a lecture with Eric Kandel. This was very exciting. So I went up to introduce myself, and he was very gracious, and he said, "Come on by and we'll meet sometime." And I went to meet with him really just to, say that I'd met with Eric Kandel, not with any designs. Well, it turned out that they had just started studying the mammalian brain like a couple years before. I didn't know this, and I was much more interested in studying. I did a basic science PhD, mostly work in mice, but at least the mouse has a hippocampus, the mouse has frontal lobe. That felt much more relevant to me. But it wasn't a plan. I just sort of, and then he said, let me introduce you to the guys and show, and they were all guys, and show you, what we're doing, and it was very exciting. So that very quickly became what I wanted to do. And what really, the things, like, what was it like? I mean, so there were 40 postdocs in the lab when I was there. It was a mammoth lab, bigger than some departments, which means that you didn't see Kandel that much. So part of what was great about it was the community that had come to work with him. And he could pick any postdoc he wanted. So he had lots of really brilliant neuroscientists coming to work with him. Almost no clinicians, almost no MD PhDs, but lots of PhD neuroscientists. So it was just a wonderful place to to work with lots of different smart people and learn from them. The questions were very interesting, and the question of synaptic plaque, both the molecular questions about mechanism that are really, core scientific mechanistic questions were interesting, but so were the conceptual questions about what is the role of synaptic plasticity, what changes it, how does that affect behavior. It was a way to try to link mechanism to observable behavior, which was brand new at that time. So all of that was exciting. I will say the other thing that was very, and then Eric, we didn't interact with him as often, but weekly. And seeing, as you said, how he always, paid attention to the details, but also kept his eye on the big picture, and trying to integrate things and use that as an intuition for what really matters was inspiring. He was a wonderful communicator, and that was inspiring. It was also a very difficult lab. It was a very political lab. Everyone was very concerned about their winning and getting the next big paper to set up their career. So it was not a nurturing lab. And that, I think, influenced me as much as the science did in two ways. First of all, I got very good at managing difficult environments, knowing when to hide, when to be seen, who to ask, just sort of managing. And that's been helpful throughout my career. Because, face it, we all deal with a lot of difficult environments. But the other thing is it taught me things that I didn't want to do. And I've worked very hard to be more nurturing and to be more, to try to build research environments in which people aren't afraid to make mistakes and admit it. And so that is another aspect that was important from that experience in my development.
Great. Still talking about Eric Kandel, I read recently a book that he wrote about the art of insight, which is a very interesting book. So, and he integrates in this book a lot of the knowledge from different disciplines, but giving a neuroscience perspective at the most. And I think in terms of my practice, thinking what I do with my patients in your talk today, I think I always try to integrate knowledge from what I'm reading, studying, today most based in neuroscience, to help the patient to understand what's going on. And usually I have a model. I always have a model that is changing all the time. And I try to share my model with the patient and sometimes listen to them. And when we work together and sharing my models with them, I not only improve my models, but also it's helpful. Frequently it's helpful for my patients.
Your patients are often very confused about what's going on, and giving them tools. Yes. And they don't have to be right. Yes. They have to be useful, right? Giving them conceptual tools to understand their own experience can, yes. For some patients think that way, some don't. But yes, but it can be. It's a useful tool for us.
So models are always wrong, right? All our models are always wrong, but they can be useful. I think in my practice it's useful to have a model, and keep me the idea that I am learning new things and creating new things. And also I myself, I always have a psychotherapist because I need a psychotherapist for myself. So I'm always having experience as a patient. Mm-hmm. And I see this ability of some patients, of some people, to organize your emotions, to understand your emotion on the different perspectives. And this is always something transforming. It's always, I think I use neuroscience to understand emotions, but there are disciplines that helps you to subjectively report your feelings. Mm. But I think there is a lot of art in this relationship with us as a doctor and the patient. And when I see that slide, that I remember that I knew that study showing that you can classify patient the schizo bipolar spectrum with different biomarkers that have nothing to do with symptoms, right? I always think where our art will be placed when if the dialogue between us and our patient doesn't have anything to do what's going on.
No, I agree. It's a little unsettling when we, are drawn to psychiatry because of the interpersonal relationship and its subjectivity, and we spend years, perfecting or improving, or practicing our ability to do that, and then the idea that might become less necessary or less central is unsettling. I have a couple thoughts. One is tough. If it's better for the patients that we can go forward to and it involves us being a little less central and a little bit less feeling less like we're in control and we have the deep wisdom that will drive it, then that's what we need to do, because we're here to help our patients. And many other disciplines have done this, and many other disciplines have resisted this. So the idea that you need to use checklists and algorithms in order to manage common presentations in the operating room or in the emergency room, this is now standard. It takes autonomy away and intuition away from the provider, and it improves patient outcomes, right? When you come in with chest pain into an ER, the provider doesn't come and do a physical exam and develop an intuition about what's going on. No, they go down the list, do this, get the oxygen, get the scan, get the EKG, right? It's very algorithmic. If psychiatry reaches a point where that's what we need to do in order to do better for our patients, then we need to do that. But the converse is, I think that there's it's enormously seductive for scientifically minded people to say that if we can measure something, then it's more important. And that leads to inappropriate or premature jettisoning of complexity, right? So what we get with our interpersonal relationships is a deep, not very objective, not very efficient, but a deep appreciation of complexity. And we get the opportunity to develop intuitions about what's going on that we never would have thought to ask, that would never come out in a questionnaire, but the patient dropped a little hint of it, and so then we follow up and we learn something that would never have come up. So something that I fear, I fear is the wrong word. I'm concerned that we as a field will be resistant to things that would move us forward, and because they will make us feel less powerful, less special, less knowledgeable, less wise. So I'm concerned that we will be resistant because we're human. But I am equally concerned, maybe even more concerned, that we will find something that works a little, and so we'll decide nothing else matters, right? Come up with a brain scan that is 80% good at categorizing who's going to respond to Risperdal. That would be great. We should use it. That would be a huge advance. And what about that other 20%, right? And what about other treatments in addition to Risperdal that might be helpful in combination, right? So I worry that we will get excited, we as a field, or the regulators, the insurance companies, others will get excited about medium-sized advances that allow us to do things quantitatively and simply, and will fall for the seductive illusion that because it's simple and measurable, it's therefore more real. I don't think that's true. So I think that we need to hold on. We need to be ready to cede some of our control when the time comes, but we also need to hold on to what does make our field special and the richness of the experiential data that we do. Yeah. I will say one more thing. I think that say someone designed a ChatGPT-based therapist that was 70% as good as an expert therapist, okay? This is plausible to me. There are people who are working on this. It's a little disturbing. People are doing it. I think it will happen, right? So if you've got a chat, now if I was going to choose my therapist, I don't want the 70%, ChatGPT therapist. I want a good, well-trained therapist, right? But if the ChatGPT therapist can get to 50 times more people who would never be able to get to a skilled individual therapist because of lack of access, failures of health systems, lack of money, lack of privilege, that would be an enormous advance. So it doesn't, like, things that allow us to do, so we can move forward by doing better. We can also move forward by doing more. And doing more not quite as well, given how many people need our help, could be a huge advance. even if it's demonstrably a little less good. Because scale matters. There's a lot of suffering people.
Thank you. So we have time for more 3 or 4 questions. Thank you.
Yeah, we're pretty out of time, but we'll take questions. Maybe 2.
So the question was, I don't think the microphone was on. So the question was, do I think that there will come a day when we have the same level of detailed understanding and knowledge of psychiatric disorders that we are beginning to have for example, cancer? Yes. I think it will take a very long time. I think that we as a field have often underestimated the complexity of the problems that we face. I mean, I remember the 1990s in America were the decade of the brain. There was new investment in neuroscience, and we were going to figure it all out. And by the end of the 1990s, we were going to be done. It didn't work out that way. I think we underestimate the complexity of the problems we face. So I think it will take a very long time for us to have a deep and satisfying understanding of psychiatric conditions. And I think it will require fundamental conceptual changes that we don't understand yet. I don't think that depression is understandable using the same conceptual frameworks as cancer, right? I think that we need to have better ways to think about the relationship between mind and brain, between psychological and physiological phenomena. I think that we need to have ways to think about, I mean, the level of complexity of information that's happening on the brain is just mind-boggling. Our intuitions are useless in thinking about, like our brains are not nearly smart enough to understand our brains. Right, our intuitions are useless to think about that many orders of magnitude of complexity and information processing. So we need fundamentally new ways to conceptual advances in addition to technical advances to get to that point, and I don't know what those will look like. And we do have to face, I just said our brains are not smart enough to understand our own brains. We may get to a point where we are good at predicting and categorizing and treating, but we really don't understand. Because what does understand mean? Understanding means we've developed an intuition where things seem fairly obvious, right? You've developed a conceptual vocabulary to think about and talk about the system that you're thinking about. You can make predictions about it, and it seems pretty obvious, right? We may never get to that point with brain and mind systems. They may simply be too complicated. So we may get to the point where we can predict with computer surrogates that help us manage the complexities. And the other way we understand, develop intuitions, satisfying intuitions about complex systems is by simplifying them in our minds, by seeing the patterns that are throwing away some of the detail and complexity, but capture the essence of it, and then developing intuitions at that relatively simple level, because our brains can only handle so much complexity. It may be that we can do that to understand the brain, that there are principles of organization that are tractable, but it may just not. It may be too complicated. So does that mean that we won't advance in our ability to diagnose and predict and treat? No, I think we will advance. And I think that we'll be able to do much, much better now than we can today. I think it will, but we may not ever understand. And it will require conceptual advances. Actually, said one more thing it will require, this isn't for understanding, but for treatment. The psychiatric disorders are caused by, many psychiatric disorders are caused by, and all psychiatric disorders are complicated by society, right? They're complicated by developmental deprivation. They're complicated by chronic stress, including systemic social stresses like racism and homophobia and sexism. They're complicated by the pressures of capitalism, by the guilt of not working hard enough that our society inculcates in all of us, and then by societal level physical things like contaminations and pollutants and Lord knows, microplastics, I don't know, and so to advance, we need to we can advance now in understanding those things. To advance in treating them, we can't do alone. We can't do them with individual patients. Medical system can't do it. It's a societal problem. And I think my optimism fluctuates on that one. So.
One last question. All right, thanks for respecting our time. Thank you so much, Chris, for your talk, and thank you, Odie, for providing us with this awesome conversation between the two of you. Hope to see you here soon again, and thank you all for coming.
Thank you all.